Welcome back to News Channel 7. We have Dr. Allison Moody here with us. She is a breast surgeon here in Bay County. And Dr. Moody, I think it's important for everyone to understand that everyone's journey is different. Let's talk a little bit about that.
Yeah, so breast cancer is such a heterogeneous disease. Anybody that comes into me for the first visit, I always start by getting a little history from them, and then my nurse prepares a packet for them that goes through every study they've had done, goes through their pathology report, and we sit down and we go through page by page and just understand, what have your tests shown? You know, how big is your cancer? How do your nodes look like? How do they feel on exam? And then really importantly, what is your pathology? You know, we say breast cancer so often. We have ductal cancers, which are our most common type, about 68%. Next comes lobular cancer, but we also have a lot of rare cancer variants, you know, things like papillary cancer. We have squamous cancers of the breast. We have adenoid cystic. We have a bunch you've probably never heard of. And all those different variants actually can sometimes change management some. So I think it's important for patients to understand what they have. Also, different variants have different degrees of aggressiveness and can drive our course differently or even our urgency differently. And then we look at receptors. We say, you know, I always describe receptors as binding sites on cancer, and there are things that will make the cancer grow. Does your cancer have estrogen receptors? Is it growing in response to estrogen? Does it have receptors for a tyrosine kinase we call HER2? And we, you know, in the oncology world, thank you to all the research, have kind of used those targets now to our advantage, where when we see large quantities of an estrogen target, we incorporate an anti-estrogen therapy. When we see a large amount of HER2 receptors on our cancer, we use anti-HER2 drugs. And I think it helps the patients to understand, I'm not just being thrown something random, you know, but I'm being thrown, I guess I'm being given a treatment directed exactly to the specific, to my specific cancer.
It's targeted, yes.
Yeah, and a lot of the treatments are actually targeted treatments. And then even our triple negatives, where we used to say we don't have a target, well, now we have immunotherapy. And we realize that for our patients that are truly triple negative, a lot of them have a really good response when we add immunotherapy, which is different than chemotherapy, as another treatment to their cancer. So, people say individualized care. Yes and no. You know, you don't want to be individualized, like your doctor makes up a regimen for you, but very directed and targeted. So, you know, we treat a cancer where we know specifically that somebody with these factors, this biology, we head down this road.
Right, and you're treating the patient.
Exactly.
Let's talk a little bit about surgery options as well, because you have lumpectomy and then you have mastectomy.
Exactly. So, you know, our options are simple and complicated at the same time. Somebody comes into me, and so many women think, I need a mastectomy to save my life. Most women, thank goodness for good screening, that walk into my life don't actually need a mastectomy to save their life. Some people will choose that. But we can talk about both options. If you can do a lumpectomy to completely negative margins with a full resection, there's no difference in survival with lumpectomy or mastectomy. In fact, we have some new data developing with regards especially to our triple negative cancers, that some of those patients may have less metastatic recurrences, meaning cancer coming back not in the breast, somewhere else in the bone, in the brain, in the lung, in the liver, with actually have less of those metastatic recurrences with a lumpectomy and radiation.
With that triple negative.
With that triple negative. So some patients I actually encourage down that road. You know, some patients have a change in their genes by numbers. About 10% of patients who have a breast cancer will have a genetic change that made them predisposed to that breast cancer.
That would be me.
That would be you. And our patients, you know, I think there's still room for choice, but in these cases, I biasly think there's a best choice. That so many of those patients, one of the things I quote is a risk of an in-breast recurrence. A lot of those people, I'm saying within 10 years, 25%.
Right.
Or a number that sounds terrible, let alone when we're diagnosing you at 30 and giving you lifetime numbers. And you know, nobody, yes, absolutely. And patients, I push down that direction. And we do a lot of genetics in my clinic. We believe in that because as much as you don't want to do breast cancer once, you really don't want to do breast cancer twice.
Well, Dr. Moody, we could talk all day, but we're going to take a quick break.